This video, presented by Dr. Ajay Kumar Tiwari, will explore the pharmacological action mechanism of beta blockers. Beta-adrenergic receptors have three subtypes: beta-1, beta-2, and beta-3. Beta-1 receptors are primarily in the heart and kidneys, increasing heart rate, contractility, and renin release when activated. Beta blockers are categorized into three generations. The first generation is non-selective, blocking both beta-1 and beta-2 receptors. The second generation is cardioselective, primarily blocking beta-1 receptors in the heart. The third generation of beta blockers includes vasodilatory and non-selective properties. Key drugs and special properties are detailed for each generation, highlighting selectivity and specific actions like intrinsic sympathomimetic activity. Beta blockers competitively antagonize beta receptors. Beta-1 blockade reduces heart rate, contractility, and renin release. Beta-2 blockade, mainly non-selective, can cause increased airway resistance, which is a risk in asthma and COPD. The cardiac effects of beta blockers include negative chronotropy, inotropy, and dromotropy, which reduce heart rate, contractility, and conduction velocity respectively. These actions are vital for their clinical use in conditions like tachyarrhythmias and angina. Beta blockers lower blood pressure by reducing cardiac output and inhibiting renin release. Lipophilic agents also decrease sympathetic outflow. Third-generation agents like carvedilol reduce total peripheral resistance by blocking alpha-1 receptors. Non-selective beta blockers are contraindicated in asthma and COPD due to the risk of bronchoconstriction. Cardioselective blockers, which primarily block beta-1, are relatively safer, but selectivity is dose-dependent. Beta blockers act as antiarrhythmic class II agents by blocking sympathetic stimulation. This decreases SA rate and AV conduction while increasing the refractory period, which treats conditions like tachyarrhythmia and atrial fibrillation. Specific non-selective beta blockers without intrinsic sympathomimetic activity, like CARDIOCAP, block sympathetic stimulation to the heart. This action reduces SA rate, AV conduction, and ectopic foci activity, classifying them as antiarrhythmic class II. Beta blockers relieve angina by reducing heart rate, contractility, and myocardial wall tension. This decreases myocardial oxygen demand, resulting in an oxygen supply greater than the demand, thus preventing angina. Selecting the right beta blocker depends on the clinical scenario. For simple hypertension, atenolol, metoprolol, or bisoprolol are preferred. For conditions like heart failure and those needing vasodilation, carvedilol and nebivolol are key choices.